بسم الله الرحمن الرحيم والحمد لله رب العالمين والصلاة والسلام على سيدنا محمد وعلى آله وصحبه وسلم. I would like to welcome all of you for attending the second RSOS 2016. It's my pleasure today to start the course on tomography and topography with the expert speaker. Our first speaker is Professor Mazen Sinjab. He will talk on topography and tomography in general. And then after that, he will talk on Pentacam, and then after that, also he will talk on the Cyrus. Please, Dr. Professor Mazen.
السلام عليكم ورحمة الله وبركاته. بسم الله والحمد لله والصلاة والسلام على رسول الله. First of all, I would like to congratulate the organizers for this very nice symposium. And I would like to thank Dr. Talal for this introduction. My presentation will be about corneal topography and corneal tomography. And I will go through the Pentacam since I'm expert in Pentacam. Sorry for this. Now, let us start with terminology. What is the difference between topography and tomography? You may find these two terms in journals and also in conferences. Actually, the first name for the instruments taking details of the cornea were topographers. Now, topography is given to those devices that are placido-based, and they give or they generate information about the anterior corneal surface, only the anterior corneal surface. And these information are translated by the computer into color-coded map. On the other hand, the topography measures directly the curvature map, and it calculates indirectly the elevation map of the anterior corneal surface. Tomography, this name is now given to those machines that are either Scheimpflug based or slit scanning, and these machines generate information from both surfaces in addition to a full pachymetry map. Now, the tomography depends on taking a slit view of the full thickness of the cornea, and it measures the elevation map directly and calculates the curvature map indirectly. So it is opposite to topography. Topography measures the curvature map directly and calculates the elevation map indirectly, and here tomography is just opposite. In addition to that, because it depends on a slit view of the full thickness of the cornea, it gives so many maps. The most commonly used maps are the anterior curvature map, the anterior elevation map, the posterior elevation map, and the pachymetry map. Now, very briefly, what is the difference between the topography and tomography, or when we should use topography and when we should use tomography? Actually, the topography gives information for the anterior corneal surface, while the Scheimpflug-based give both surfaces. In topography, there is no pachymetry map, while in the Scheimpflug-based there is. The most important thing is the topography gives better details for corneal periphery, while the tomography gives better details for the central of the cornea. When we have any corneal scar, even subtle scar, like post-PRK haze, the tomography is not accurate, especially in the pachymetry map. It is not accurate because of the scattering of the light. While the topography can give us better details for the anterior corneal surface in case of haze and scars. For this reason, the topography is a must when we want to go for topo-guided treatment, while the Scheinflug-based can be used as a diagnostic tool. So topography is a must when we want to go for topo-guided treatment. There are 3 major machines in the market: the Pentacam, Galilei, and Cyrus. And since I am expert in Pentacam, I will go into details in this machine. I will show you how to adjust the settings before going to study the 12 points, and then we will have one clinical example. Before we start studying the tomography of the Pentacam, we have to use the 9mm display. Why we should enlarge the display into 9mm instead of 11? Because when we have black dots at the periphery of the cornea, as you see here, this means that there are missing data, and the computer has extrapolated these areas, assuming these areas according to the nearby clear areas. So when we enlarge into 9mm display and we find these dots have disappeared, so the quality of this picture is acceptable. Look at this example. Although we have enlarged into 9mm, but still we have many missing places, data. So in this case, I will not accept this picture, and I have to recapture the patient. Number 2, I have to use the absolute scale, color scale, 1 diopter increments, because this is the standard international scale, in order to make these pictures comparable to other machines and from one visit to another visit of the same patient. For the elevation map, I have to adjust the diameter of the reference body to be 8mm because it is a standard. And I use 5 micrometer increments between colors because better to give details and better not to exaggerate the small details. For the pachymetry map, I use the 10 micrometer increments. Now coming to the 12 points to master corneal tomography. There are 12 points that we should look at on the Pentacam in order to be sure that there is no risk if we want to go in terms of corneal refractive surgery. Before I start, I would like to say that we can take an idea from the machines, from the indices they give, but we should not depend, we must not depend on the diagnosis they give, because they give an objective estimation of the cornea. We have to depend on our subjective estimation of the cornea, because if we depend on the diagnosis the machine gives, it means that we are as if we are depending on autorefractometer to prescribe glasses, which is not correct. So whenever you see these indices, you can take an idea. And even the manufacturer, they recommended that it is just to pay attention, but you should not depend for diagnosis. The same for Belen-Ambrosio display, because this display, although it is very important, it is not 100% specific, not 100% sensitive. So we have false positives and we have false negatives. So what are the 12 points that we should study? We should look at the quality specification, the quality of the picture. It should be okay in a white box. Then we look at the value of the Kmax, maximum K reading, thickness at the thinnest location, the vertical coordinate of the thinnest location, the astigmatism, topographic astigmatism, Q value. Q value describes the asphericity of the cornea. And then I have to study each map. The first one is anterior curvature map, then the anterior elevation map, posterior elevation map, pachymetry map, and then I go to the profile, thickness profile. The thickness profile describes the progression of thickness from the thinnest location towards the periphery of the cornea. The red curve here describes the curve of the examined eye, while the black dotted lines are for normal population. So we have to study the shape, and we have to study the average progression, as you see here. The last point is we have to compare between both eyes. I cannot give a decision when I see only topography from one eye. It is very wrong. So many times when my colleagues send one eye topography and ask me for my opinion, I have to see both. Starting with the quality specification, when it is okay, it means that all data are complete and within the acceptable range according to the machine. While when I have yellow, like data or something, it means that there are missing data and I have to recapture the patient. The cutoff point for the Kmax is 47.2 diopters, above which it is abnormal. When I say abnormal, it does not mean keratoconus. It is just abnormal. Keratoconus is a syndrome. It is a collection of abnormalities. The cutoff point for the thinnest location is 500 micron. The cutoff point for the Y coordinate or the vertical displacement of the thinnest location is minus 0.5. Minus means downward. Coming to the astigmatism. Astigmatism should be, if we have against the rule astigmatism, this is against the rule astigmatism. The cutoff point for the against the rule astigmatism is 1.5 diopters, above which it should be suspicious. And when we have oblique astigmatism, above 2 diopters should be considered as suspicious. In addition, we have to compare between the topographic astigmatism and the manifest astigmatism. The topographic astigmatism, of course, is not the topography from the anterior corneal surface only. It should be the total astigmatism. But because the pentacam does not give us the total corneal astigmatism, I depend on the algebraic sum between the anterior and posterior surfaces. In Galilei, there is total astigmatism. It can give us the total astigmatism. So, when there is a difference more than 1 diopter between the amount of astigmatism, topographic astigmatism, and that of the manifest astigmatism, it should be suspicious. And when there is a difference more than 15 degrees between axes, it should be suspicious. Q value, the normal Q value is between 0 and -1. Above -1, like -1.234, it means that the cornea is very prolate, it's very steep, like after hyperopic treatment and like keratoconus. While we see plus, like plus 0.5 or plus 1, after myopic ablation, in which the cornea becomes very oblate, very flat. Now, this is my classification of the risk factors. Starting with, we have high risk factors and moderate risk factors. Starting with the high risk factors, when the thinnest location is below 470, when the Y displacement of the thinnest location is above -1 millimeter, we have moderate risk factors when we go to the topographic astigmatism and when it is oblique and above 2 diopters, or when it is against the rule and above 1.5 diopters. Both are moderate risk factors. When the thinnest location is between 470 and 500, it is moderate risk factor. So below 470, it is high risk. Between 470 and 500, it is moderate risk. When we have the Y displacement between -0.5 and -1, it is moderate. Above -1, it is high risk. Q value, when it is out of the range, it is moderate risk factor. We have to look why it is out of this range. Now coming to the pictures or the maps, starting with the sagittal curvature map. There are different patterns on the curvature maps. I used in previous conferences just to present them without classifying them into high risk, moderate risk, or low risk. I'm going to classify these shapes into symmetric shapes, asymmetric shapes, skewed shapes, and special shapes. So 4 categories. Regarding the symmetric shapes, we have round, oval, and symmetric bow tie. So symmetric bow tie, it is not the only shape that describes the symmetric cornea. There is oval and there is round also. These shapes are considered normal when the Kmax is below the cutoff point. Coming to the asymmetric shapes, we have the superior steep when we have superior hotspot. When we have asymmetric bow tie, superior steep, inferior steep, and asymmetric bow tie, inferior steep. We used to say that these shapes are abnormal. This is not true. They might be normal. We will see how. We have to look at the 2 opposing points on the 5 millimeter circle or 4 millimeter circle, as you see here. And then I go back to these pictures. When the shape is superiorly steep, as these 2 shapes, when I have the difference less than 2.5, then it is normal. And when I have the inferior steep shapes, when it is the difference between the 2 opposing points is below 1.5 diopters, then these shapes are normal. So not every asymmetric shape is abnormal. The skew shapes, we have 2 shapes, the symmetric bow tie with skewed radial axis and the asymmetric bow tie skewed radial axis. Also, we used to say that these are abnormal, but they are normal when the difference between axes, as you see, is less than 22 degrees. When the difference is above 22 degrees, they are abnormal. We have special shapes like butterfly, crab claw, and vertical D, smiling face, in addition to irregular shape, which can be seen in scars after previous surgeries or when we have pterygium. Now let us classify these shapes into high risk when I see skewed radial axis above 22 degrees. When I see these special shapes are always abnormal, always high risk. And when I have the symmetric shapes, as you see, symmetric shapes, but the Kmax is above 50. So it is high risk in these cases. Now coming to moderate risk. When we have symmetric shapes and the Kmax is between 47.2 to 50. So above 50, these shapes are high risk. Between 47 and 50, these are moderate risk. Also, when I have asymmetric poti, inferior steep or inferior steep, and the difference is above 1.5, it is moderate risk. Coming to the elevation maps, we have symmetric shapes on the best fit. If I want to study the shape of the elevation map, I have to use the best fit sphere, not the best fit toric ellipsoid. It should be the sphere. So on the sphere, we have hourglass, and we have central island. Both are symmetric.